chaos exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Good almost afternoon, everyone. Welcome to this very special presentation of our the Center for Health Evaluation and Outcome Sciences Work in Progress series. I know many people in the room, but those that I don't know here and on Zoom, my name is Amy Salmon. I am the Associate Director of the Center, and it is my absolute pleasure today to welcome our special presenter, Dr. Hannah Carver. So Dr. Carver has an impressive list of accomplishments and appointments that I require a list in order to remember fully. She is a lecturer in substance use at the University of Stirling in Scotland, where she is also the co-director of the Salvation Army Centre for Addiction Services and Research. Her work centers on drug and alcohol harm reduction approaches, homelessness, marginalized communities, and families affected by substance use. And we're very lucky to have her visiting Canada for 3 weeks. She's nearing the end of her 3-week tour, so we're especially grateful that she's made the time to come be with us at the conclusion of her studies, where she's traveling here as part of a Society for the Study of Addiction traveling scholarship to learn more about drug checking, managed alcohol programs, and other harm reduction approaches. So please join me in welcoming Dr. Carver.
Thanks, Amy, and thanks for welcoming me. So I was invited, so I've worked with Amy on a research project around parents who use opioids in Scotland and in England. And Amy invited me to come and speak to you today about Scotland's response to drug-related deaths and harms. And really, I'm here in Canada to learn about what you seem to be doing far better than us here than we do in Scotland. But I thought I'd share kind of some of the things that what Scotland's doing to kind of tackle drug-related deaths and harms, and see whether you think that what we're doing or you're doing, there's things that we can learn from each other. So looking at kind of different approaches, including research that I've been involved in, as well as kind of national approaches and interventions. So I don't know how much people know about Scotland, so I thought I'd give a bit of context. Scotland's one of the 4 countries that make up the United Kingdom, along with England, Wales, and Northern Ireland. It's pretty small. I think it's actually smaller than BC. Is approximately 30,000 square miles in size and has a population of 5.5 million people. And it's famous for things like haggis, iron brew, bagpipes, and unfortunately, drug-related deaths. So we're a small country with quite a few problems. And just a bit of context also that Scotland is part of the UK, but quite a lot of our policies and approaches, including healthcare, are devolved, which means they are governed by the Scottish government rather than the UK government. And a bit of context also that the UK government is much more conservative than the Scottish government, so they view that drug and drug policy much kind of more harshly than the Scottish government. So things like healthcare, homelessness and alcohol policy sit within the Scottish government, but drugs policy sits within the UK government. So that creates lots of challenges, lots of barriers, particularly due to the UK Misuse of Drugs Act, which came in 1971, which is very old, older than me, and therefore very much outdated, which means that when we're trying to change Scottish policy, we're told by UK government that there's really very limited things we can do, and I'll discuss that in terms of particular interventions. So as you can see from this slide, Scotland has far more drug deaths per capita than any European country. And although this is data from kind of 2019, that's still not really changed. And we also have the highest drug-related death rates across the 4 UK countries as well. I don't really have time to go into all of the explanations because there are many as to why why we're so high with our drug-related deaths. But it includes things like poverty, government legislation and policies. And one of the kind of key explanations for understanding why we've got such high rates of drug-related deaths is due to deindustrialization in the 1980s, and then the subsequent economic and social hardship that people experienced as part of that, as well as the related intergenerational trauma. So moving kind of all of these industrial jobs like shipbuilding were all kind of stopped, which meant that there was lots of poverty, and that's caused lots of problems for generations to come. And importantly, people living in the most deprived areas of Scotland are much more likely to use drugs. I think it's around 18 times more likely than those living in affluent areas. So you can see this kind of long-term impact of things that happened in the 1980s and beyond. So in Scotland, we've obviously got quite a small population, and there were 1,300 drug-related deaths in 2021, which is an age standardised rate of 25 per 100,000 of the population, which is comparable to, well, it's highest in Europe and is comparable to US and Canada. I think it's higher than some provinces in Canada, but probably lower than here in BC. And it's also important to note that there was a 500% increase in drug-related deaths from 1996 to 2021, so things are getting considerably worse. And just to note, in terms of how drug-related deaths are measured, this relates to deaths that were directly caused by drugs, so an overdose death. And it doesn't take into account other kind of deaths related to drugs, which might be things like liver failure, long-term health conditions, etc. So obviously deaths related to drugs will be much higher than captured in these figures. Also, it's, as I said, people who live in deprived areas are much more likely to use drugs, but they're also 15 times more likely to die as a result of drugs, and men experience are much more likely to experience drug-related deaths than women, although unfortunately rates among women are increasing. And in Scotland, deaths generally occur between those aged between 35 and 54 years, so a reasonably young cohort, although people are termed older drug users when they're over 35 because of the health conditions. And as I said, there's a range of kind of complex factors that relate to, that kind of explain why we have such high rates of drug-related deaths, things like poverty, reduced funding for drug services. So it's the same here, where all the money has kind of been taken away from services for people who probably need a lot more support. We've got high rates of polydrug use. So in 93% of the deaths, more than one drug was used, and quite often it would be a mixture of heroin, benzodiazepines and cocaine, as well as alcohol. And we also have a quite increasingly complex and variable drug market, and we don't, spoiler alert, we don't have drug checking yet, so we don't actually know what's in our drugs. So all of these factors putting people at risk, and our kind of approaches to drug-related deaths are relatively minimal, I would say. So just in terms of a bit more depressing statistics for you, as you can see, the rates of drug-related deaths have increased dramatically in the last kind of 10 to 13 years. And as I said, most of these deaths are due to opiates or opioids, benzodiazepines, gabapentin or pregabalin, and cocaine. And as you can see, as I said, polydrug use, so there's kind of multiple substances being used all together at the same time. Scotland also has quite a love of street or novel benzodiazepines, and these are implicated in lots of deaths, and you can see the kind of real dramatic increase from kind of 2014 until now. So in 2015, for example, there were 191 deaths related to benzos, and over 900 in 2021, so almost 5 times as many. And these deaths are being driven by street benzodiazepines. So these are benzodiazepines that are often sold as prescription brands like diazepam, but they're actually not. They're not diverted from prescription. They are created and are much more potent and could contain like a number of different substances or different benzodiazepines in one tablet. So obviously much stronger and are more likely to result in an overdose. And people generally think that they're buying, for example, diazepam, and we'd know the dosage of that, and it's not that. And again, we don't have drug checking yet, so we can't test the potency or the type of substances within the pills. And then just a bit more kind of context as to why there might be kind of particular issues. So drug possession is still a criminal offence in Scotland under the Misuse of Drugs Act. And as I said, drug laws are not part of the UK government's powers. And these kind of legislative changes lie within the UK government. And the UK government, despite talking about a kind of expansion of diversionary schemes, has really stated that they do not support decriminalisation of personal possession, and they were kind of really explicit in making this clear. Whereas in Scotland, there's a kind of push towards decriminalisation. In 2019, we had a kind of policy process through the Scottish Affairs Committee, where they kind of took together lots of evidence around drug-related deaths and harms, speaking to experts, etc., and conducted an inquiry into problem drug use in Scotland. And they recommended that the UK government should adopt a public health and evidence-based approach, that they should reform the Misuse of Drugs Act, that we need better funding in Scotland. They should support the planned safe consumption site in Glasgow and ensure it's able to be lawfully implemented. They should decriminalise small amounts of drugs for personal use and should be doing everything it can to reduce stigma. But unfortunately, I don't really see many ways that this has really changed over the last few years. And I think just in terms of kind of Scotland, we have moved towards a more kind of public health oriented approach to policing towards drug use in Scotland, rather than kind of automatically putting people within the criminal justice system if they're caught with small amounts of drugs. And we had kind of recent changes to laws in Scotland where the Crown Office, who would oversee kind of police powers in Scotland, have said that officers can now issue recorded police warnings for class A, B and C drugs, which means that they can utilise discretion and provide a recorded written warning to someone who's found in possession of a substance, rather than them being charged with an offence. But because it's to their kind of discretion, it doesn't necessarily mean that that's the kind of blanket policy across Scotland. And it also means that people who probably are known to the police, who are known to be using drugs, will be much more likely to be criminalised than those whose maybe it might be a first offence. So yeah, we have all this kind of policy context and lots of kind of issues around kind of how drugs are legalised or not, and how it's kind of treated within a Scottish context, just to kind of get you to understand where we're coming from and how challenging it is to kind of put towards or kind of take forward really kind of novel harm reduction approaches when things are really challenging from a kind of legal standpoint. So in terms of kind of, there's been a few main kind of policy approaches to drugs within Scotland that are particular to Scotland, that are a kind of way of trying to kind of I guess battle against the UK government's more punitive approach to be able to kind of be more supportive towards people who use drugs. And there's that general public health approach to drugs where there's been a significant amount of investment, for example, within treatment services. We have new standards around medication assisted treatment that I'll talk about in a bit. We've got expansion of naloxone, and then potentially, hopefully, the introduction of things like safe consumption sites or overdose prevention services, drug consumption rooms, as well as drug checking. But at present, we don't have things that you might have here. So we don't have safe consumption sites. People generally would inject their drugs on streets and alleyways in their accommodation. We don't have safe supply. We don't have heroin. Well, we do have a heroin assisted treatment, but it's very small. We don't have drug checking. And surprisingly, we don't have sharps bins and toilets, which I've discovered is completely widespread here, and it's not a thing in Scotland, which amazed me. But there's kind of growing support for a lot more kind of novel approaches or kind of much more harm reduction oriented practice within Scotland. So I'm going to talk more detail about each of these kind of particular approaches that Scotland is taking. So in terms of the public health approach to drugs, as I said, there's a move away from criminalising people and an emphasis on treatment and harm reduction. And we've got a couple of, so our drugs policy document called Rights, Respect and Recovery really takes a public health approach to prevent both preventing and reducing drug and alcohol use, harms and deaths. So there's things kind of around particular approaches to drugs, not just benefiting the person who uses drugs, but also wider communities, family members, friends, and where they live. There's a kind of a focus on prevention of drug-related harms and kind of tackling inequalities, so supporting young people better, so that kind of preventing them from using drugs or at least delaying it till they're a bit older, trying to kind of build better communities for people to kind of tackle that high number of kind of high rates of deprivation. And also this kind of focus on an evidence-informed approach. There's quite a lot of kind of real interest from the Scottish Government about research, and a lot of research has been funded within the drugs field in Scotland over the recent years, which I can talk about in a bit as well. So in 2019, Drugs Death Task Force was set up to support our policy and to identify measures to improve the health of people who use drugs by preventing and reducing drug use, harm and related deaths. And this task force kind of was set up to examine the kind of key drivers of drug deaths and advise on further changes in practice or the law that could help to save lives and reduce harm, to develop recommendations around kind of what needed to be done in Scotland in order to kind of reduce the issues that are currently being experienced. And the Drug Death Task Force was made up of a range of people who worked in the field, including academics, policymakers, people working within healthcare and kind of not-for-profit services, people who use drugs and family members, police, etc. So quite a wide range of group, and they had kind of subgroups as well. And over £9 million was invested in 2021, and 5 million in the subsequent year. And 3 million of this was for our alcohol and drug partnerships. And these are kind of groups of alcohol and drug kind of commissioners who would work out how to spend funds across local areas. So we've got these alcohol and drug partnerships across each kind of local authority in Scotland, so like the provinces here. So services have been funded to do things like increase naloxone supply, outreach service, which provides prescribing and mental health assessments, etc. Increased injection equipment provision. For example, one area included a bus that would go around and provide injection equipment provision to people. Increased support for people who are leaving prison, and the use of peer researchers, as well as the introduction of depot buprenorphine. And as I said, there was also quite significant investment in research projects, over £700,000, and there's kind of a wide range of projects, including looking at primary care and preventing drugs, evaluation of peer-to-peer naloxone training and supply programme, which I was involved in, perceptions of people, key decision makers and family members about drug consumption rooms, looking at how ambulance call-outs were involved in drug overdoses, and around benzodiazepine prescribing, so kind of safe supply. And they also provided more than 8 million in a kind of innovation and development fund for services. For example, this included things like a pilot to train police to carry naloxone, overdose response teams, the medication-assisted treatment standards that I'll talk about. It also funded our work around drug checking. as well as kind of other services like clinical psychologists, etc. And then they also provided funding of £500,000 for digital inclusion, so providing digital devices and support for people who use drugs as a way to kind of tackle a range of issues. And I can talk about that a bit later as well. And they also had a real focus on tackling stigma by producing a strategy paper that kind of really challenged views around stigma and ways that services and other people could work towards this, as well as media guidelines. I don't know how bad it is here, but in Scotland, the media are terrible when they talk about people who use drugs, very stigmatizing language, and it is getting better, but these guidelines kind of say, stop using photos of people slumped on the streets and stop calling people addicts and junkies and things. So it still happens, but there's definitely, you can see a kind of move away, and the media are much more supportive and kind of person-centered. We've also more recently had a national mission on drugs deaths, which was established in January 2021, which was supported by £50 million of funding between 2021 and 2026. And the aim of this mission is to reduce drug deaths and improve the lives of those impacted by drugs. And there's a focus on kind of prevention, reducing harms related to the use of drugs, and kind of supporting people to get into high quality treatment and recovery services, as well as addressing the needs of people who use drugs with multiple complex needs, as well as supporting families and communities who are impacted by drug use. So they've kind of looked at key outcomes in terms of kind of preventing people from starting to use drugs in the first place, reducing the risk for those who do already, ensuring people have access to appropriate treatment and recovery, however that may mean for them, not necessarily abstinence-based. Kind of Scotland's moving towards recovery being very kind of broad and about kind of participating in society rather than expecting abstinence. Improving people's quality of life by addressing multiple disadvantages, which would include kind of things like housing and poverty and stuff, as well as supporting children, families and communities. So another kind of policy approach that's happened in Scotland in recent years are the medication assisted treatment, or MAT standards, and these were prioritised by our drug deaths task force to provide a framework for services working with people who use drugs, to ensure that medication assisted treatment is safe, effective, acceptable, accessible and person-centred for people for as long as they need. So this would be when people access services, for example, for methadone, buprenorphine, etc., they were able to get kind of the best high quality service that they can. So these standards were kind of moved or taken out to all services who work with people who use drugs. And the purpose, as I said, is to kind of improve access and retention within medication assisted treatment, enable people to make informed choices about their care, so not necessarily expecting everybody to be on the same treatment, but having a choice as to what treatment works for people. And this can involve family members as well, and also kind of ensuring that there's particular necessary governance and resources in place to implement these effectively. So you can see from the screen there are 10 of these, and they're all about kind of accessing medication from like on the same day, having informed choices, offering evidence-based harm reduction, allowing people to remain in treatment for as long as possible, as long as they want to be, so not kind of expecting a very short time scale. Having a system that's psychologically informed and trauma informed and kind of understands the co-occurring drug use and mental health problems that people might have, and really providing support for people to access housing, welfare and income needs. So really seeing drug use in this kind of wider context of kind of multiple layers of difficulty and complexity, and supporting people in a much more kind of person-centered way, as that has generally been lacking in some services. So in Scotland, we introduced naloxone in 2021, and it was 2011, and it was the first national naloxone programme in the world, which allowed people to be provided with naloxone who were at risk of drug-related deaths, and that was funded by the Scottish Government. And then in 2015, there was an amendment which meant that people would be able to get naloxone without a prescription from drug services. So it made it much kind of more widely available. And then during the pandemic, there was a kind of sense that, well, actually, if only drug services are providing naloxone, there's a huge gap, particularly if some of these services were closed or kind of were temporarily, like their operating hours were reduced. So this temporary measure, which is luckily still in place, was passed to enable individuals other than drug treatment service workers to distribute naloxone. So it means that naloxone is much more widely available. Anybody can get it. You can access it through an organisation called Scottish Families Affected by Alcohol and Drugs. You can get injectable and or nasal spray, and all you have to do is to kind of do a kind of 10-minute e-learning thing about how to use naloxone. So really the rates of naloxone kits being distributed has really increased, and more than 120,000 have been distributed over the last 12 years. We've also had now that police officers and firefighters are carrying and administering naloxone only in the last year. Paramedics can issue it following an overdose. So if someone overdoses and they go to the scene afterwards, they can give a kit out. And we've had peer-to-peer education program, which was established in 2012. And also there was examples of naloxone being carried by taxi drivers, local kind of politicians and councillors, pub and bar staff. So a real kind of push to get naloxone much more widely available and less stigmatized, which is great. Just a kind of, it's an aside, it's relevant, I think, to drug policy, but it's slightly different in that we have Housing First in Scotland, which for those of you who don't know, but I'm sure everybody probably does, means that it's non-kind of abstinence-based housing. So people would be given their housing without any conditions placed on accessing treatment for their mental health, their substance use problems, etc. It was first established in 2018 and has provided more than tenancies to more than 500 people in the initial 3-year period. And Scotland has been seen as this kind of pioneer of Housing First implementation because there was a real strong political commitment, and it was something that happened really quickly in terms of kind of scaling it up from a small pilot site that was delivered by a small kind of not-for-profit organisation to something that is really widely available. And just kind of, there's been quite a lot of work and evaluation and evidence that those who were involved, most were men aged 26 to 49 years, and pretty much all of them were white British and heterosexual. So it really kind of targets a particular group of people experiencing homelessness and mental health and substance use problems within Scotland. But evidence that people have been able to sustain their tenancies and have been able to kind of do that for quite a significant long period of time, but the evaluation has shown that there's still barriers in terms of helping people to access healthcare. So it's kind of addressing potentially their housing problem, but not necessarily addressing things around mental health or drugs or alcohol. And unfortunately, of the people who were housed within the time when the evaluation was conducted, 6% died, and the deaths were mostly due to drugs and alcohol. So there's that kind of real need for more support for people who are using drugs. And the evaluation then also concluded that there's need for kind of sustained support for Housing First. So it's not going to be the kind of panacea for kind of reducing homelessness and drug-related harms, but is one kind of particular approach that does seem to be working in Scotland, which is also good. And I just thought I'd talk about kind of other things that we're doing before I move on to kind of things that we're wanting to do in Scotland. And recently, I was involved in some work around a anti-stigma campaign for people who use drugs and their families to kind of, or it's an anti-stigma campaign that shows the impact to people when they've lost or lost a loved one due to drugs and or alcohol. And we took inspiration from a Canadian campaign called See Beyond, See the Lives, that you might be aware of, that was I think came out in 2019. So we involved 14 people across Scotland who wrote a letter to their friend or family member who died as a result of drugs and or alcohol. And you can have a look at these videos that are really powerful on our website, which you can see below, and looks like this. And if you've seen the Canadian version, it's very similar, but we had kind of extended it to be alcohol as well as drugs, and family members as well as friends, whereas they were parents who'd lost a child due to drugs. So these are the things I've talked about before, kind of the things that Scotland has, and now I'm going to move on to the things that Scotland wants or is hoping to have in the kind of next few years. So it makes sense for Scotland to have drug consumption rooms because we know the evidence shows that they really work in terms of reducing overdose. There's been no deaths within drug consumption rooms since they've been introduced globally. And there's support within Scotland for the establishment of safe consumption sites or drug consumption rooms, however you wish to call them. But attempts have been blocked by the UK government. As I said, they think it'll support drug use. Ridiculous. So the Scottish Government produced an evidence paper in 2021, which really detailed the evidence and support, particularly in Glasgow, where there's been really high rates of HIV. And you might be aware, if you follow Scottish kind of drug policy Twitter, that we had an unsanctioned drug consumption room ban in 2020 by a kind of activist called Peter Crikant in Glasgow, who supervised more than 900 injections and reversed 9 overdoses. But it was unsanctioned, and there was obviously kind of a legal grey area, which has meant that it's been unable to continue. And there's been research in Scotland that's shown high willingness from people who inject drugs to use safe consumption sites, support from family members, and also decision makers are strongly supportive, but there's that kind of uncertainty about legal and political mechanisms. And I'm involved in research currently around the potential for introducing these services within Edinburgh. So I think it's going to be one of these things that we still need a bit more time to look at how it would kind of fit within Scottish policy and law, and also how it would kind of work within in practice within services that are already existing. So hopefully watch this space. There'll be some, but not right now. So I was very excited to come here and visit a few when I was in Victoria, which was great. And as I said, also, we don't currently have drug checking. And these are services, I'm sure you probably all know, allow people to get their substances tested and be provided with information about the content of their substances and get harm reduction advice. There's several drug checking services across Canada, as well as the US, New Zealand, and across Europe. There's been piloting of services in England, and the Loop, who are the kind of at the forefront of drug checking in the UK, and do lots of festival-based testing, are preparing to launch a regular community-based service in Bristol, but currently no drug checking services in Scotland. So I was involved in some research over the last couple of years, looking at how we can kind of inform service delivery with the kind of view of doing some research, informed practice for then services to be set up. And we're really hoping that they're kind of making really good progress towards that. And hopefully by the end of this year, we'll at least have one drug checking service established in the community in Scotland. And I won't go into detail around kind of licensing and stuff because it's pretty complicated and don't have massive time, but yeah, there's lots that can be done. So we did some research where we interviewed various people and talked about kind of perceptions of drug checking, how it would work in practice, looking at kind of barriers and facilitators, as well as conducting a realist literature review about the factors that kind of increase engagement in community-based drug checking. And as I said, we've really used this research to inform practice, and quite often research will take 17 years to inform practice, whereas we started this in January 2021, and we're hoping the service will be finished by the end of this year, which is very much research into practice much more quickly than I've ever experienced, which is exciting. So we've done this realist review, which you can have a look at, which looks at the kind of programme theories about the factors that increase engagement in community-based drug checking, looking at the international evidence, and lots of interesting kind of factors around perceptions of drug checking, how people would kind of access it, what are the kind of legal barriers that people might experience. So if you're interested in drug checking, I suggest you have a look, and I've got a reference at the end that you can have a look at. And in terms of our kind of research, we provided people with kind of vignettes of drug checking to provide information about what drug checking services could look like, because people weren't really they wouldn't have an understanding of what drug checking is because it doesn't exist here. So we had different examples. For example, one situated within a not-for-profit service, one within our healthcare service, and one that would be in a pharmacy. And we asked people, like, in your experience, how would you feel about these services as a service user, as a family member, or as someone who might be working in these? And as you can see, generally the third sector service and the pharmacy were much more popular, but people did not like the NHS service, our kind of national healthcare. And we think this is kind of because there's kind of negative experiences of quite abstinence-based punitive treatment within some drugs services run by the NHS. So there's maybe a thought that drug checking within this kind of approach would potentially reduce, maybe kind of address those previous negative experiences, but actually having it in a not-for-profit, as it generally is here, or within a pharmacy, would be much kind of more appreciated. And you can see these are the kind of benefits and challenges that people really talked about. So importance of trust, having more support and kind of wraparound care, being able to kind of offer something that was quite accessible and discreet, and then concerns about particularly around confidentiality, not having particularly useful spaces, etc., under resource services. So we kind of looked at a lot of perceptions and barriers, and the services who are implementing drug checking, 2 of them have decided to use the third sector site and 1 in a pharmacy. So nobody's gone for NHS, so they've definitely listened to the research, which is good. And just in terms of kind of our intervention components, there was a range of kind of factors that were shown to be really important when implementing drug checking in Scotland, and some of these will likely be of use internationally as well. So things like trusted spaces, confidentiality, non-judgmental staff, having a small enough sample to for checking rather than having to give over too much of your drugs, and things around kind of location and the size of the service, etc. And our research also looked at kind of public and community attitudes. So people were really clear that drug checking services might be quite controversial for some people, and might be kind of stigmatizing, but there's a kind of real need for such services within Scotland. As someone says, you'll always get hostility towards it, but if it saves someone's lives, then it doesn't matter if people are hostile, we can just kind of get around that. And our research also showed that it's really important to involve a wide range of people within planning and consultation. These are quite complex services within a complex kind of policy system. So ensuring everybody's on board, including people who would use the service, is really important before you kind of open the doors, which obviously is the case for lots of complex interventions. One of the services that we do have, but is relatively small, is heroin-assisted treatment service, which opened in Glasgow 4 years ago. And it's people who are very high risk, who use heroin, who are experiencing homelessness and at high risk of drug-related deaths and harms. There's been some evaluation that's been carried out, but this isn't in the public domain yet. But there's some evidence that the people who have been accessing this service and they get injectable diamorphine are those that are most vulnerable, and have been able to get other needs addressed, like housing and kind of welfare, etc., and engage with a wide range of services. So the kind of preliminary data is showing it's really helpful, but it's one very small service in one city, so not particularly accessible to many people, so something that really needs to be scaled up quite a bit. In terms of kind of digital inclusion, I'm sure it was the same here, but there was a lot of kind of increase in digital technology, and it really highlighted the digital divide among people who use drugs and the kind of wider society. So the Scottish Government funded some work around drug-related deaths and digital inclusion, which helped people to become more digitally connected to services and people around them. So services were given money to provide devices to people, employ people who were digital champions, and get training and support. And I was involved in the research around this programme. So we looked at how people would, how they currently use technology through a survey and through focus groups with people who use drugs and service providers. And we found that people generally use digital technology, but had kind of concerns around access to devices or money for devices. We're not very kind of digitally literate, and we're mistrusting, and service providers kind of needed more support in training themselves. We also did a literature review which looked at kind of digital technology that I won't go into more detail, but there's kind of much more work that you can have a look on the Digital Lifeline Scotland website. And then we evaluated the programme to look at the perspectives of those involved, and showed that there was lots of devices and connectivity provided. Very few devices were lost or stolen, and this was seen as something at the beginning that the press picked up on, saying, how dare you give all our public money to people who use drugs because they're just going to sell their phone and use drugs. But actually that wasn't the case. And people really kind of benefited from having devices and being able to connect, and a feeling that being given a device showed that someone cared, which is kind of important as well. I'll skip that. And we've just done a bit of work in Scotland around kind of prevention, but it's very kind of minimal compared to the amount of kind of research and funding that goes into treatment and kind of harm reduction. So this was research that looked at the kind of benefits of our programme from Iceland around kind of holistic prevention. And we conducted some research and knowledge exchange activities to kind of understand whether it could work in Scotland. Our work involved bringing together groups of people to kind of review the evidence base, and following that process, there's been funding from the Scottish Government to introduce this approach in Scotland to kind of address particular challenges that have been involved. I just wanted to show you a nice comic that we worked with a young woman who was a comic artist who created these comics to kind of capture our journey, and it's kind of a really nice way of making research and knowledge exchange a bit more interesting, rather than it being just all kind of academic words. And then we also did some work around people's perceptions of this prevention, and there's a real kind of sense that Scotland needs prevention. It's at the moment we really have kind of basic education in schools, which is rather terrible and kind of still goes around that that kind of language of just say no, which we know doesn't work. So this is more about kind of tackling wider issues, providing people with kind of things to do other than going out and getting drunk and using drugs and smoking and things like that. So people were generally in favour, but thought there would likely be some kind of cultural differences between Scotland and Iceland. There's similarities, but it's quite a different country. Again, kind of buy-in would be needed for this kind of long-term funding of a prevention project, because it's generally quite, it's just a kind of pilot at the moment with very little funding and no evaluation at the moment. So I think that's probably all. I've put some resources that I can send these slides around if people are interested in some of the work that we've done or colleagues have done. And then I thought I'd end with some questions about how Scotland responds to drug-related death and harms compared to Canada's. How can Scotland learn from Canada's resources? And is there anything that I've talked about that you think is missing from how kind of drugs are dealt with in Canada? So thank you.